Assalamu alaikum wa rahmatullahi wa barakatuh. Peace be upon you. Welcome to this evening CME hosted by the Islamic Medical Association and generously sponsored by Diagnose. This is the second CME. We've had a successful one on COVID recently and plan to have a CME at least once a month. We thank you for your time and enjoy this following program. Our guest speaker tonight is Dr. Nasrin Goolam. Nasrin is an endocrinologist. She trained at Nelson Mandela Hospital, did her fellowship at Wits University, and completed her PhD after receiving the Carnegie Fellowship. Her PhD was entitled Challenges in the Metabolic and Cardiometabolic Aspects of Psoriasis. Nasrin is a true academic, trained under Professor Muhammad Tikli, one of our Imei models. We've got a lot to learn from Nasrin today. Nasrin, extremely qualified. She received numerous awards. Notably, she was the best student in her final year, both in undergraduate, as well as receiving the Ashad Dab prize in her FCP. Nasrin is an excellent teacher. She has supervised numerous MMeds and is also on an editorial. We'd like to first and foremost thank Nasrin for giving up her time. The program for tonight will involve a talk by Nasrin, a Q&A session. I'd like to urge you all to go on to mute. And under the chat group, there will be a link that I'd like to ask you all to do this registration form as well, either during the talk or during the Q&A session. Any questions, please put in the chat group and we'll try our level best to address them. Nasrin.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, friends and colleagues. Thank you, Ahmed, for that very kind and generous introduction. It's a pleasure to be here this evening. I just want to load my talk and then I'm going to begin. Can everyone see that clearly? Ahmed, are we good?
Good, thank you.
Thanks. So I want to start by thanking the IMA, Jazakallah to you for hosting this meeting. And thank you to Marianne van Biljon and to the team from Novartis for inviting me to speak tonight. Also, I really appreciate that so many of you have taken time at the end of what was almost certainly a really tough day to listen to this presentation. My talk this evening is entitled Challenges in the Management of Type 2 Diabetes. I want to add that this talk was originally entitled The Difficult Diabetic. One of the reasons I changed the title was that someone pointed out to me the redundancy in my choice. I am sure we all have discovered at some point in our careers that there is no such thing as a simple diabetic patient. So here I am presenting to you a standard disclaimer slide, which I'm obliged to show you. But I want to start by briefly outlining the talk for this evening. I will begin by discussing some of the challenges in the management of type 2 diabetes. We will talk about the epidemiology of diabetes with particular reference to Africa and look at a little bit around the pathogenesis of type 2 diabetes. Thereafter, we'll look at the management principles in the context of the current guidelines, local and international. The second half of the talk will focus on some case studies. The first looking at a newly diagnosed patient, the second an older patient with renal impairment, and lastly, a quick look at a patient with diabetes who would like to fast during Ramadan. I should point out to you that these are scenarios that will demonstrate aspects of clinical reasoning, as opposed to structured cases with discrete answers. So thereafter we'll conclude, and hopefully we'll have some time for some robust discussion. Almost every diabetes talk begins with some version of this slide, which shows you the global prevalence of diabetes and its projections going forward. What you can see is that there will be a 51% increase in the prevalence of diabetes over the next 25 years, from 463 million, which was 2 years ago, to almost 700 million in 2045. Now, this data and this particular map comes from the International Diabetes Federation Atlas, which is the most recent version released in December 2019. What is most alarming, however, is that the highest increase, which is almost 150%, is in sub-Saharan Africa. And if we are to interrogate these numbers even more closely, most people who are diagnosed with diabetes in sub-Saharan Africa are under the age of 50. A large percentage of these patients are female. And 3 out of 4 deaths due to diabetes in Africa are in people under the age of 60. In Africa, we have a dual burden of both communicable diseases, such as HIV and tuberculosis, and now the staggering burden of non-communicable diseases. And I cannot stress enough the importance of addressing the burden of type 2 diabetes appropriately. Historically, type 2 diabetes was understood within the framework of what is known as the so-called triumvirate. Hypoglycemia was driven by the interplay between impaired insulin secretion from the pancreas, peripheral insulin resistance, in other words, decreased glucose uptake in skeletal muscle, and increased hepatic glucose production via gluconeogenesis. Within this framework, treating type 2 diabetes involved initiating therapy with lifestyle modification and metformin therapy. And if therapeutic targets were not met, one would add preferentially a sulfonylurea, and it was almost invariably a sulfonylurea. And if this was not appropriate, either basal insulin or thiazolidinedione. And at the next level, in other words, at step 3, whatever step was not used in step 2 was then alternated at the following level. However, this framework has evolved and expanded significantly in the 21st century. And we have moved from the triumvirate to what is now known as the ominous octet. And this was elegantly described by Ralph DeFronzo in a seminal paper in 2009. Now, I know it can look very daunting to look at very complex pathogenetic models, right? However, I want to simply highlight a few things that are very important when we look at the novel drugs that are available for type 2 diabetes. So the new model highlights the role of the gut hormones. It also highlights the role of the kidney and the role of neurotransmitter dysfunction in hypoglycemia. What is important is that each of these pathogenetic mechanisms is a target or potential target for anti-diabetic therapies. Also, what you see here is the role of adipose tissue, and specifically visceral adipose tissue has an important contribution to play in hypoglycemia via the pro-inflammatory mediators released by adipose tissue. We know also that this inflammation is an important pathogenic mechanism in atherosclerotic cardiovascular disease. Moving away from the basic sciences, I want to address the management principles in type 2 diabetes. The bulk of this presentation will focus on strategies to improve glycemic control. But I want to preface that by reminding you that multifactorial intervention is essential in patients with diabetes. And this has been demonstrated in numerous studies over the years. And one of those that has done it particularly well is the STENO2 study. What it showed was that intensive multifactorial therapy could decrease mortality by 45%. In addition, it could prolong survival by up to 8 years. It could prolong the time to the first cardiovascular event by over 8 years and significantly decrease microvascular complications. So what does intensive multifactorial intervention mean? And the truth is, it involves fairly simple strategies. lifestyle intervention, smoking cessation, addressing body weight and obesity, achieving optimal glycemic control, treating blood pressure targets, using antiplatelet therapy where appropriate, and very importantly, addressing lipid targets. I want to highlight at this point that our lipid targets and patients with type 2 diabetes are considered very high risk, so that they should be treated at an optimal lipid target of 1.4 millimoles per liter when it comes to addressing their LDL. And this is according to both the ESC and the South African guidelines. What you're looking at here is the 2017 SEMSA algorithm for the management of type 2 diabetes. It simply begins with metformin monotherapy, which you can see here, and it moves sequentially for dual, triple, and then complex therapy. Sorry, I think the mouse is quite sensitive on this machine. So, following metformin therapy, one would add either a DPP-4 inhibitor or glycoside modified release, shown in green as preferred options for dual therapy, with the addition of either a thiazolidinedione or an SGLT2 inhibitor. Could you excuse me for a moment, please? I'm sorry, I have a little bit of a problem on this end.
While Nasrin is waiting to come and talk, we'd just like to ask the audience, if you do have any questions, please post in the chat and we'll address it towards the end. And if you could please link, if you fill out the form that has been put into the chat, you could link the information for the CLE points. Thank you.
Sorry, Ahmed, can you hear me?
Can hear you fine, Nasrin?
But I don't seem to see my screen, which is where I think I'm having a problem. Can you see my slides?
We can see it. You can just magnify.
Let me see if I can get back to it. Sorry about that, everyone.
No problem.
Dr. Nasrin, if it makes, if it would help, maybe just stop sharing completely, and then just share your presentation again.
Okay, let's try again. Are you able to see that now?
We can see it fine, thanks.
Can you just put it in presentation mode?
There it goes.
That's it. And then Dr. Nasrin, somebody just asked, the little screen at the bottom right is blocking some of the
It's distracting.
visuals.
Sorry about that. Yes.
There we go. Thank you.
Sorry about that, everyone. Okay, so I'm going to start again, starting with this slide, looking at glycemic control according to the SEMSA algorithm for type 2 diabetes. Right, so we start with metformin monotherapy and move sequentially to either DPP-4 inhibitors or modified release glycoside, shown in green, as the preferred options for dual therapy, with either pioglitazone or an SGLT2 inhibitor shown in the light purple as the alternate options. But the one thing to bear in mind is that these guidelines were written in 2017, which was before the cardiovascular outcome trials for these drug classes, like the SGLT2 inhibitors and the GLP-1 receptor agonists, which are not recommended as dual therapy in these guidelines. So these guidelines are most likely due for an update given the new data we have from the cardiovascular outcome trials, and the ones I'm referring to in particular are EMPEREDGE, the LEADER trials, as well as the SUSTAIN trials. But one could therefore look at the European and American consensus statements, which, and this is what we have from the EASD and the American Diabetes Association, which looks at a more comprehensive model which takes into account the novel agents. Now, I know it looks fairly complicated, but you could allow me to walk you through it, right? So first-line therapy is metformin, as it is in most guidelines. And if the HbA1c is above target, one would have to proceed by stratifying our patients as to either having established atherosclerotic cardiovascular disease or chronic kidney disease, or those who do not have these comorbidities. If patients fall into the former category, then one would be selecting either a GLP-1 receptor agonist or an SGLT2 inhibitor. But you should bear in mind that if heart failure or chronic kidney disease predominates, then one would favor the SGLT2 inhibitor because there is far stronger evidence for benefit of this class of drugs with heart failure or chronic kidney disease. In the absence of established cardiovascular or kidney disease, one is to take a few other considerations into account. Is there a compelling need to minimize hypoglycemia? Is there a compelling need to minimize weight gain or promote weight loss? Or is cost a major issue? If cost is the major factor in treating type 2 diabetes, then one would have to use either sulfonylurea or thiazolidinedione. However, if cost is not a major issue, then one would take the other factors into account and individualize therapy using any of the novel agents, depending on the patient's profile. And one could then escalate using alternate agents, going down the algorithm, as you can see here. Before I move on to the next part of the case studies, I just want to say a few words around hyperglycemia. Now, we know that the current SEMSA algorithm also puts an HbA1c threshold at 7% in general. But this may be adjusted to a tighter target of 6.5% in a young patient with no comorbidities, or possibly a higher target of perhaps 7.5 to 8.5% in the frail elderly patient with comorbidities. We know that persistent hypoglycemia will increase the risk of complications in type 2 diabetes. But the converse is that intensive glycemic control significantly increases the risk of severe hypoglycemia. And this dilemma presents an ongoing balancing act for the clinician. The impact of glucose-lowering therapies, and in particular our novel agents, is complex, and individualized therapy within the framework of existing evidence and current guidelines is essential. However, as we all know, this is easier said than done. And with that, I'd like to move on to the first case I have for you today. And that is the case of Mr. X. He's 45 years old. He works as a driver and he was diagnosed with type 2 diabetes just around 6 months ago. He has a body mass index of 25 kilograms per square meter, which is basically on the border of being overweight. He's been started on metformin monotherapy and has been tolerating it well. The glycated hemoglobin at this visit is 7.5%, and he has no evidence of complications. So, my question is, what would be the next most appropriate step in the management of this patient? But we'd have to take a look at a few considerations before we can answer that question. Firstly, is this patient at the correct glycemic target? If not, what is the correct glycemic target for this patient? Are there any specific treatment considerations in Mr. X, and which therapies would we consider in his management? So, going back to the patient, before we can decide on a specific target, let's look at what is unique in Mr. X. Firstly, he is a young patient. He's been diagnosed with type 2 diabetes relatively recently, and his glycated hemoglobin is above the SEMSA threshold. Lastly, he works as a taxi driver, And this is an occupation where a hypoglycemic episode could have potentially disastrous complications. Now, I'm just going to walk you through some of these considerations before we come to the answer to the original question. First of all, why was the threshold of 7% selected as the glycemic control target in type 2 diabetes? And the answer is based on data from the UK-PDS study, which showed that microvascular complications would increase as the HbA1c rose above the 7% threshold. In the graph on the left, what you see is that the gradient for microvascular endpoints, shown in blue, increases as the HbA1c, shown on the x-axis, increases above 7%. On the right, you can see this probably more clearly for retinopathy, where the, sorry, I think there's some feedback there.
Speak it louder.
So what I was showing you was for retinopathy, that above the 7% threshold, the incidence, the prevalence of diabetic retinopathy increases significantly. Hence, we have the 7% threshold. We've also learned from UK-PDS that for every 1% reduction in HbA1c, there is a manifold risk in a reduction in complications of diabetes, including a 21% reduction in deaths from diabetes, a 14% reduced risk of myocardial infarction, a 25% reduced risk of microvascular complications, and a 43% reduced risk of peripheral vascular disorders. So, hopefully I have demonstrated to you so far the importance of achieving a lower HbA1c in this patient. But I would go as far as to argue that in this particular patient, I would aim for a target of 6.5% in him, provided he was not having hypoglycemic episodes. And if you're not entirely convinced, I should remind you that he's a newly diagnosed patient with type 2 diabetes, and early glycemic control is pivotal to a reduction in the long-term complications of diabetes. This is a phenomenon known as the legacy effect, and it was demonstrated in the long-term follow-up of both the UK-PDS and VADT trials, in other words, the Veterans Affairs Diabetes trial. A good legacy effect is what was shown in people who were treated with intensive therapy in the arms of this trial, and they achieved a long-term reduction in microvascular and macrovascular complications, whereas those who were treated with conventional therapy were not able to achieve the same reduction in micro and macrovascular complications. So, achieving glycemic control late in type 2 diabetes after a prolonged period of poor glycemic control does not improve one's long-term risk of macrovascular disease. In other words, achieving optimal control early in the course of diabetes reaps long-term benefits, which cannot be compensated for by delayed intensification of therapy. So coming back to the South African guidelines, which I'm trying to do here, we can see that our patient would be eligible here for either a DPP-4 inhibitor or modified release gliclazide. And however, theoretically, using a sulfonylurea, which is gliclazide, would theoretically put this patient at risk for hypoglycemia. However, I should point out that the modified release preparation has the lowest risk of hypoglycemia of all the available sulfonylureas on the South African market. So briefly, what I have demonstrated here are the symptoms of hypoglycemia. And I know they are probably well known to you, but they are simply worth reiterating because it's such an important symptom. And what I want to highlight is that hypoglycemia can also occur during sleep. And nocturnal hypoglycemia may not be something patients are aware of unless one specifically elicits this history. And one would have to ask questions related to night terrors, possibly night sweats, or feelings of confusion or irritability on waking, which A patient might not volunteer unless one specifically asks these questions. A quick basic science slide to demonstrate why sulfonylureas would cause hypoglycemia, and the answer is pretty simple, is that they bind to the sulfonylurea receptor and act as insulin secretagogues, so the hypoglycemia is mediated by the insulin release. An important point to note, though, is that patients who do have hypoglycemia as a result of sulfonylurea use may have prolonged hypoglycemia as a result of the long half-life of these drugs, right? As for the second drug, the DPP-4 inhibitors, these work on the incretins, and in particular GLP-1, which is secreted by the L cells of the ileum. So the enzyme dipeptidyl peptidase 4 is responsible for breaking down endogenous glucagon-like peptide 1, and it does so fairly rapidly. However, by inhibiting this enzyme with the DPP-4 inhibitor, one is able to increase endogenous GLP-1 and allow a longer half-life of endogenous GLP-1. So for Mr. X, what would be the next step in his management? And he could be given a sulfonylurea, or he could be given a DPP-4 inhibitor, and both of which would be fairly simple, cost-effective treatment strategies in a newly diagnosed patient. I would add the caveat that if one was to use a sulfonylurea in this patient, one would advise him quite strictly about the symptoms and signs of hypoglycemia and change if he were to experience these symptoms. So before I move on to the next case, I would like to show you some data from the Verify study. This is a trial that was published in The Lancet 2 years ago, and it looked at the comparison between early combination therapy using metformin and vildagliptin versus monotherapy with metformin alone. And the primary endpoint was the time to initial treatment failure. It was really asking the question whether early combination therapy would provide glycemic durability, which monotherapy could not provide, because monotherapy is working along the principle that our guidelines suggest, in that we use monotherapy and only when patients have failed, then you sequentially move on to additional drugs. So what the trial showed was that the initial time to treatment failure with metformin was approximately 3 years, but this extended to over 5 years with early combination therapy. And as you can see at 61.9 months, most patients with early combination therapy had still not failed on this combination. And this represents a relatively safe and well-tolerated approach for early treatment in type 2 diabetes. The drawback, of course, is there would be a subset of patients who would be overtreated because they would not need dual therapy at the outset. And of course, further studies would be needed to identify which patients would most benefit from early combinations. So now moving on to the second case, we have Mrs. Y, who's 75 years old. She's a pensioner and lives alone. She's been diagnosed with type 2 diabetes for the last 30 years. She's overweight, has a glycated hemoglobin of 8.5% and an estimated GFR of 35 milliliters per minute. Her comorbidities include hypertension, osteoarthritis, and she's had a previous hip fracture. And she's currently treated with metformin and a sulfonylurea. So the questions are pretty much the same in this patient as well. Is she at the correct target? And if not, what target should we be aiming for? What are her treatment considerations and what therapies would we use in her? So first of all, she is certainly in the older age group. She has long-standing diabetes with an HbA1c that is well above the target of 7%, but it may not necessarily be inappropriate for her. She is overweight, and she has comorbidities, including comorbidities that have been associated with the risk for falls. Over and above this, she lives alone. Right? What we should keep in mind, though, is that she has a low GFR of just over 30. So this, again, will change our therapeutic choices in this patient. So what could we do? First of all, I think it would be important to stop the metformin and sulfonylurea. Alternatively, you could consider using a lower dose of metformin or a renal dose of metformin. However, my advice would be to simply stop in this patient and consider the use of either a DPP-4 inhibitor or an SGLT2 inhibitor, which would not be associated with the risks of hypoglycemia. The alternative option in this patient, which I haven't included on this as a correct answer, so to speak, is the use of basal insulin. Basal insulin would remain a viable and cost-effective option in this patient, provided she would cope with daily injections and provided she would cope with the monitoring of her fasting glucose to make sure she was not going hypoglycemic. So the last case, which is a fairly, one more thing to quickly point out to you. If we were using an SGLT2 inhibitor in this patient, there would be a few things to highlight to her. The first is the higher risk of genital mycotic infections when starting an SGLT2 inhibitor, as well as the potential risk of euglycemic diabetic ketoacidosis in these patients. If the patient was using an SGLT2 inhibitor concomitantly with insulin or an insulin secretagogue, there would be a significantly increased risk of hypoglycemic effect. And a diuretic effect may be observed with an SGLT2 inhibitor if it was used, and it would be a potentially additive effect if it was used with loop diuretics. In this particular patient, this last point may be even more important because of the blood pressure lowering effect that the SGLT2 inhibitor may have in this patient, and it may further aggravate her risk for falls. So the final case is that of Mr. MM. He's a middle-aged man with type 2 diabetes for a year. He has good glycemic control. He's known with hypertension as well, and he is currently on only oral anti-diabetic treatment in the form of metformin and a sulfonylurea. So he asks, can he fast during Ramadan? Now, my answer to this particular case is going to be fairly short, given the time and given the fact that the full answer to questions like this are probably beyond the scope of this talk. But I would definitely refer you to the practical guidelines, which were updated this year, and they can be found on the IDF link and the Diabetes and Ramadan Alliance website. But it is well worth referring to these guidelines when managing our patients who plan to fast during Ramadan. For this patient, given that he is well-controlled, newly diagnosed, and only on oral anti-diabetic agents, there is no contraindication to him observing the fast during Ramadan. He has the option, certainly, of continuing the sulfonylurea and metformin. However, there would be a risk of hypoglycemia using the sulfonylurea, and one may consider changing the timing of it to the iftar meal. Alternatively, he may need a slight dose reduction of the sulfonylurea if there is a risk of hypoglycemia. The other alternatives are to change to an alternate agent for the duration of Ramadan, in other words, to continue the metformin, but to add either a DPP-4 inhibitor or a GLP-1 receptor agonist for that time. So with that, it brings us to the end of this talk. And I simply want to reinforce that treating patients with diabetes encompasses numerous challenges. And the effects of the glucose-lowering therapies, and in particular the novel agents, are complex. Individualized therapy is integral to patient compliance and improved patient outcomes. The one final thing which I want to highlight is that a large part of our focus should be on the newly diagnosed young patients with diabetes to give them the benefit of a good legacy effect and to prevent the onset of complications rather than struggle with managing complications in the future. Ladies and gentlemen, thank you for your attention.
Thank you so much, Nasrin. So while we are waiting for questions to come through, we'd like to thank Nasrin for her time. We will take questions through the chat group. And as you can see, the link has been created where you can apply for CPD points. So Nasrin, this is out from the very basics, the diagnosis of diabetes. Could you just go through that? For example, the HbA1c, is that enough to diagnose diabetes, and what level to look at? Besides that, the fasting glucose, what levels you should look at? Just unmute yourself, please, Nasrin.
Sorry about that. So there are a variety of ways to diagnose type 2 diabetes. I think the first thing is, in the presence of symptoms, you simply need one biochemical test to diagnose diabetes, and that would be either fasting glucose of over 7, a random of over 11.1, or an HbA1c of over 6.5%. In the absence of symptoms, I would strongly suggest that you repeated whichever test proved to be high in the first place, rather than, unless they were so overtly high that the patient was obviously diabetic. However, with mild elevations, I think it is sensible to have a second test, and this is what the guidelines suggest. And more we see people using the HbA1c to diagnose type 2 diabetes, and there's nothing wrong with this, provided you have a lab that has a validated HbA1c assay, and that the patient has no conditions that may invalidate it, for example, severe anemia. The other thing is the HbA1c can't be used to diagnose gestational diabetes.
Excellent. The first question that comes through is a teenage girl with investigations are suggestive of insulin resistance. The example is a young female, age 17, fasting insulin of 11, fasting glucose 4.6, normal BMI, blood pressure and lipid profile. Patient is fully compliant with lifestyle modification. What would you suggest in a young female with insulin resistance?
So I think, first of all, I'm not really comfortable answering for a specific biochemical profile. Right? It's not really a good idea to manage a patient on a platform like this. But I would caution against managing patients based on a single insulin level or even serial insulin levels. I think insulin resistance is associated with a wide variety of conditions, but insulin resistance in and of itself is not a diagnosis. It is a pathogenetic mechanism that may be associated with type 2 diabetes, polycystic ovary syndrome, or maybe other more insidious conditions. But also the assay is something that can fluctuate literally from day to day. So I would be very cautious about saying that your diagnosis is insulin resistance and to simply treat a number.
Second question that comes through is, we're in the COVID third wave currently. You can see that diabetes or diabetic patients, especially the obese diabetics, are really at the brunt of this pandemic, where you can see the mortality is so high. The question that comes in from one of our IMA members is, can you explain the management of a COVID patient with diabetes who needs these high levels of steroids?
So that is really a diagnostic, a therapeutic challenge, right? And it is probably one of the most difficult things to deal with the COVID pandemic. We know that our patients with diabetes are at very high risk of developing severe COVID and requiring all the additional medical therapy that COVID requires, including the glucocorticoids. So it would be impossible to avoid these. The bottom line is that they would need intensification of their anti-diabetic therapy. And ultimately, what we have seen is that almost all patients require insulin or further intensification of insulin therapy if they are on high doses of glucocorticoids. And Amit, have I lost you?
We here, thank you.
Oh, sorry. So the point is simply that when we're intensifying anti-diabetic therapy, particularly in patients who are seriously ill, those who are critically ill, those who are hospitalized, insulin is probably the only way to go. My advice, though, is for those patients who have severe COVID and who have diabetes, I would be very reluctant to manage them at home without the advice of a specialist, and I would strongly advise that they be referred for inpatient management.
I can assure you that we're seeing a lot of these COVID patients in the hospital, ICUs, and it is a challenge. And I think this is where also the question of lipids coming to as well because of this metabolic profile. I think a short mention on LDL. Nasrin, we always want to target our LDL as low as possible. The patient, what's your advice of how low should we go?
So I think when it comes to LDL reduction, we should be treating all our type 2s as really high risk, and they should be treated as the cardiovascular disease risk equivalents. So one as low as you can safely go, but definitely not more than 1.4. And this is not something that can be achieved in most patients with a low dose of a statin. Most patients require a moderate to a high dose of a statin, and those who don't achieve it with a single statin would require a more potent statin or combination therapy with ezetimibe.
So it's very common when we're having these patients come through, and the management we've been trying to do is give these patients high-dose statins. And I think diabetes is a cardiovascular risk factor. So as Nasrin mentioned, target the LDL below 1.4. A very topical question that's coming from one of our guests is, what's your view on semaglutide? And I think it's an excellent question. I knew it was going to come up. What's your question on this for weight loss and insulin resistance?
So again, I think we are confusing two things here, right? I think anyone who is overweight will have insulin resistance. And whether semaglutide is not necessarily the treatment for insulin resistance, it will address the underlying condition, which would be to target the weight. And the results, so in the space of the GLP receptor agonists and in the incretins in general, it is a very exciting space because a lot has been released and is going to be released. So semaglutide is probably the newest kid on the block, literally days into its release, and it looks extremely promising, not only for glycemic control, but also for weight loss. And the weight loss results from the SUSTAIN trials is far greater than any of the other GLP-1 receptor agonists to date. So I think that's going to be very exciting. I think the other big advantage of this molecule is that it is a once-weekly administration, which will be a huge advantage for patients in terms of compliance. The one caution, although it hasn't been a common side effect, is in the SUSTAIN studies. I think it was SUSTAIN 6 that showed this. There has been a worsening of diabetic retinopathy in patients who receive semaglutide, independent of the improvement in glycemic control. And in patients with severe diabetic retinopathy, it's something to be cautious of.
There's been a pregnant patient that refuses an oral glucose tolerance test. Besides HbA1c, what else would you recommend to diagnose diabetes, or any other test that you would suggest?
I don't understand why would a patient refuse a test that was in their benefit. It's a really simple test, and unfortunately, it is the only validated test for the diagnosis of gestational diabetes. If you were able to do a fasting glucose and the fasting glucose was over 7, you would be diagnosing overt diabetes in pregnancy and you'd have an answer. But in the absence of that, it would be very difficult to diagnose. So I'm going to elaborate a little more here because one is because gestational diabetes is a topic very close to my heart, and the other is that it is something that I think that is sometimes under-addressed. The oral glucose tolerance test in gestational diabetes is not the same as in the non-pregnant state. It is a 2-hour test, but the samples are taken at 0, 1, and 2 hours, and the cutoff thresholds are not the same as in the non-pregnant state. They are lower. So the only way to detect that lower level of dysglycemia, which is different from pre-diabetes, is to do an oral glucose tolerance test if one is to do so reliably. If the patient has really high sugars, over 7 or over 11.1 at 2 hours or random, then you have a diagnosis and you could probably get away without the OGTT. But if the patient is at high risk and if the patient has persistent glycosuria, you do need an oral glucose tolerance test.
Just to go through the questions, because we've got about another 10 or 15 minutes to go through. What's the risk of hypoglycemia in type 2 patients with regards to exercise? So I think they're asking, the doctor's asking about what's the, I suppose, the risk of, I'm not sure whether he's asking regarding the falls or what's the impact of having low glycemia.
So I think the answer would be it depends on the therapy that the patient is on. So if the patient is on insulin or if the patient is on an insulin secretagogue, then it would really depend on their on the way their meals are timed and the carbohydrate load of their meals. But with moderate exertion and oral anti-diabetic medication, it would be unlikely to precipitate severe hypoglycemic episodes. In type 1s, especially those on multi-dose insulin injections, that's a completely different story and also a more complex one. But in type 2s with moderate exercise, I'm not sure if it is I'm not sure I understand exactly what the colleague would like to know.
Let's go to the next question, which I think is a good one. It's what's the impact of inhaled steroids? So our asthmatic patients that are taking diabetic therapy.
So I think if taken correctly and in the correct doses, they shouldn't have a major impact because they shouldn't be systemically absorbed. However, although some studies do show some systemic absorption of steroids, I do not think they are to the point of a deteriorating glycemic control. Oral steroids are a completely different story, of course.
A very good question. One of the guests is, would you routinely put diabetic patients on statins, irrespective of the cholesterol level? And maybe I could just ask does the lipogram need to be a fasting lipogram?
So, two things. As for the routinely putting them on statins, I've heard this question answered in different ways. Some people would say yes, absolutely, and others have said not necessarily. The truth is, I think that we have to look at the target LDL. We've seen a lot of African patients, particularly at Baragwanath Hospital, who have, even within the presence of type 2 diabetes, who have such low lipids that adding a statin would not necessarily lower it any further, and literally LDLs in the region of 1.2 without any statin therapy. However, I have never seen these levels of LDL in any other race group, and my experience is that it is almost impossible to get to an LDL of 1.4 without the use of a statin. As for fasting versus non-fasting lipograms, there is some evidence to say that a non-fasting lipogram may be adequate. unless, of course, the patient has had a very high fat meal prior, in which case it would certainly skew the lipogram. The other thing is that if the patient has hypertriglyceridemia or mixed dyslipidemia, then the fasting lipogram would definitely, a non-fasting lipogram would definitely markedly elevate your trigs, and you wouldn't get a true representation of the triglycerides. So I think you'd have to watch the levels in a particular patient. Personally, I request fasting lipograms in everyone to simply standardize it.
Excellent. I'm learning a lot today, Nasrin, so thank you for all of these brilliant answers. Question, hypoglycemia and the incidence of ischemic heart disease. Is there an increased incidence of coronary events?
With
hypoglycemia?
That is a great question. It's a difficult question to answer. So if we look back at the data from the ADVANCE and ACCORD studies, right? Those were landmark studies from the NEJM quite a few years ago now. And what they were looking at was to try and achieve tight glycemic control in patients with type 2 diabetes to try and decrease the macrovascular complications in type 2 diabetes. And what ultimately happened in ACCORD was that they had to decrease they had to stop the trial prematurely because of the increased mortality in the tightly controlled group. And ADVANCE also didn't show a decrease in cardiovascular mortality despite tight glycemic control. And there was the suggestion that hypoglycemia may cause an increase in macrovascular events. However, while we know that in patients at high cardiovascular risk, we want to avoid hypoglycemia, to date, there has been no study that has shown a causal association between hypoglycemia and myocardial infarction.
Just to add maybe from the cardiology part is that a patient that has hypoglycemia, you're clearly going to exacerbate your type 2 MIs, your supply demand. You're going to increase your risk of an arrhythmogenic event. Hypoglycemia could cause cerebral perfusion issues. So clearly, we should try our best to avoid hypoglycemia. Question about lipoprotein A. If your lipoprotein A is low, should you still aim for an LDL of less than 1.4?
So I think this question is probably one of those I would put to Prof. Rao, and I'm going to have to acknowledge the limitations of my answer here. For me, I think in clinical practice, a normal fasting lipogram is what we're going to be looking at. And I think there's a lipoprotein little a is something you would use for research purposes, but for the day-to-day management of your patient, I'm sorry, I'm going to have to apologize. I can't give you the correct answer to that because I'm not sure right now.
Okay, I see some delegates have their hands up to ask questions. Please post it in the group, your questions, and we'll address it verbally. How often should you monitor a COVID diabetic patient who is on prednisone, PD? We've got a few minutes left, so I'd like to maybe keep the answers very short. And if there is anything pressing, we'd like to close up soon.
So I think a patient who is on oral glucocorticoids should simply be managed with finger prick glucose monitoring. And if they're on insulin, this would be multiple times in the day, 3 to 4 times in the day, if not more. And if they are on oral anti-diabetic agents, then less frequently would be fine. I don't think biochemical monitoring, meaning HbA1cs, would be of any benefit in the acute setting.
This brings us to a short question on Forxiga. It's contraindicated in severe renal failure, but obviously the cardiovascular benefits is astounding. So would you recommend for your patients with moderate renal dysfunction, which would be your agent of choice?
So I think, we've been used Forxiga is dapagliflozin. The actual benefits have been demonstrated with EMPA. Right, the EMPA Forxiga doesn't have the same benefits as the Emperor's trials, right? But the GFR cutoff is 30 mils per minute. So above that, I would be happy. Below that, I would be cautious. I don't know if, particularly with newer agents, I would be reluctant to be using drugs without the advice from a nephrologist. I think it would be safer to follow the guidelines and go with the 30 mils per minute threshold that is recommended for those agents.
Okay. Another question that comes through is, so if we just go back to regarding the Victoza or the Trulicity and these agents for weight loss. Patients need to then continue using it to maintain weight loss. And I know it's a difficult question because obviously the whole thing of diet and everything comes into it, but do patients need to long-term pursue this therapy?
So I think weight loss is a fraught issue. It's in fact probably the topic for an entirely different CME, Ahmed. The truth is, every study with weight loss has shown that once patients come off the weight loss therapy, they will gain the weight. And a lot of our patients believe that they have there's a quick fix, which there isn't, right? There's no cure for obesity, and the only sustained therapy that has been shown to work is bariatric surgery. And beyond that, any weight loss therapy has been shown that the weight will be regained over a period of time, if not necessarily immediately. Semaglutide has shown more sustained weight loss than the other agents, but even then, I don't think that data is really available just yet. I wouldn't. I think the simplest answer is that weight loss is a more complicated issue that needs to be addressed at multiple levels and not just with a single agent.
We have so many more questions to answer, but unfortunately we've got to cut it short. We'd just like to mention, Idu, could you put on the CMEs? We've got a few CMEs planned in the coming months. Just like to thank Nasrin for her time, her expertise. We really learned a lot. For the general members, we like to encourage you to get involved with the IMA. There's numerous programs currently, obviously COVID and helping out in the COVID facilities. There are a lot of groups that are going on. Please, we'd love you to volunteer. The IMA obviously is involved in a lot of screening programs, involved in cataract programs, dialysis programs. Please, we'd like you to assist. There is a virtual IMA symposium that we are planning later on in the year. As you can see, the dates have been earmarked for the 9th and the 10th of October. Any suggestions, please forward to Kashifa. We thank you for your time. We thank the sponsors, Novartis. We thank Kashifa for always being there with the organization skills. We pray that Allah Ta'ala keeps you, your family safe over the next coming and trying period. We all are going through a lot at this moment, and we'd like to thank the Almighty for keeping us safe. For those of us that have lost loved ones, we pray that you granted a lot of sabr. And we'd like to also extend our gratitude to all the healthcare professionals for helping out at this period. As you can see, there are a few webinars that are being advertised via social media chats. If you do have any topics of interest, please, we'd love you to give suggestions. To end off, thank you all very much for attending tonight. The CPD program points will be emailed to you. And we thank you and good night.